Greetings. Let us learn about medical management of acute pancreatitis. I'm grateful to my mentor, Dr. John Stroline, Mr. Charles Butt, Miss Angela Deal, my institution, and my mentors. Please read this notice. So you're called in to see this patient in the emergency room, room number 10. And this patient was admitted at 6 o'clock this morning. And based on her story of severe epigastric pain, deep boring pain that continued for several hours and radiated to the back, along with vomitings, you wonder about the possibility of pancreatitis. And you looked at the labs, and the amylase and lipase were in thousands, at least for sure, more than 3 times the upper limit of normal. So with these two findings, pain and elevated amylase and lipase, more than 3 times the upper limit of normal, you make a diagnosis of acute pancreatitis. You also check if they have done a CT scan, because emergency room physicians tend to do a CT scan quickly, and you notice that the pancreas was swollen and inflamed, and you make a diagnosis of acute pancreatitis. And you look at the clock. Patient was admitted at 6. Currently, you notice that the patient, it's about 5 minutes to 7 a.m. What are you going to do to manage this patient? So in order to understand this, let us go back to the pathology. And as you can see here, the pancreas is inflamed, and you make a diagnosis of pancreatitis. And in acute pancreatitis, there is inflammation and edema, and also loss of fluid due to extravasation of fluid. It results in a retroperitoneal burn and leads to extensive third space fluid loss. So a couple of liters can be easily lost within the first few hours, and that leads to volume depletion. So it is important to consider fluid resuscitation to control and correct that volume depletion. And by doing that, in a very prompt way, as soon as you see the patient, that would prevent that interstitial pancreatitis from getting into necrotizing pancreatitis. Say, for example, that has not happened and the necrosis developed. And in this case, the necrosis leads to catabolic state, and it is important to keep in mind that you should correct that by prompt nutritional support. So in acute pancreatitis, keep in mind volume depletion needs to be corrected, catabolic state needs to be corrected. In addition, you also take care of the pain. So with those principles, let's get back to the room. Here is our patient. The patient was already given some pain meds, and you look at the vitals, you notice that the heart rate is 140, systolic blood pressure of 80, diastolic 40. That leads to a mean pressure of below 60, and oxygen saturation is 92%, and a respiratory rate of 18. So you recommend aggressive and prompt hydration. And when it comes to what type of fluid, would you give saline, normal saline, or IV ringer lactate? IV ringer lactate is better because of its anti-inflammatory properties, and the calcium in the ringer lactate is likely to uh, prevent further activation of the trypsinogen to trypsin. So lots of benefits. And unlike it is a more basic solution, so much better compared to normal saline. You decide about aggressive hydration with IV ringer lactate. Because this patient is volume depleted based on rapid heart rate, low blood pressure, and you decide to give a bolus. And how much a bolus should you give? Based on the recent New England Journal study, the waterfall study, you give a bolus of 10 ml per kg. And then following that, you give about 1.5 ml per kg per hour of IV ringer lactate. So that's what you're going to do. So you don't, in acute pancreatitis, you should be closely monitoring the patient. And in the next 6 hours, you monitor the heart rate, you monitor the blood pressure closely, you monitor the urine output, and you also repeat the hematocrit and BUN. So if you find that the response is not adequate and the hematocrit is still high, heart rate is still high, blood pressure is still low, urine output has not picked up, in that case, you may repeat another bolus and continue at 1.5 ml per kg per hour. What we have learned is in acute pancreatitis, it's better to give boluses of 10 ml per kg and a rate of 1.5 ml per kg per hour, and close monitoring to aggressively correct the volume depletion. And also be careful not to volume overload that patient. So that is really critical. Say, for example, this patient this patient had come in, and you notice that the heart rate has improved, the blood pressure is improving. In that case, you continue ringer lactate at 1.5 ml per kg per hour. It is critical to manage acute pancreatitis with fluid ringer lactate rehydration in the first 24 hours. They may require up to 3 to 4 liters based on their BMI status. And that first 24 hours is critical. That is one that is going to prevent the interstitial pancreatitis from going into necrotizing pancreatitis. Because by aggressive hydration, correcting the volume deficit, you are going to let that pancreas perfuse, and with that perfusion, you are limiting the possibility of necrosis. But it's also important, as you're doing this, you want to avoid fluid overload. So you want to constantly be checking the respiratory rate, their oxygen saturation, checking the lungs, check for any crepitations or development of fluid, or maybe need an X-ray of the chest to check, and looking for the abdomen to see if the abdomen is getting distended too much and they're developing like a compartment syndrome. So correct the fluid loss, but avoid fluid overload. That's the principle. So you should keep this thing in mind. But if you manage your fluids well in the first 24 hours, you may save the patient from getting into necrotizing pancreatitis. The difference between interstitial pancreatitis versus necrotizing pancreatitis is that interstitial pancreatitis patients will go home within a few days. Once necrosis sets in, They will be in the hospital for several days to weeks, and they may require multiple interventions to get them back to uh, recovery. So something to keep in mind. So we discussed about fluid. The other important aspect is to manage the catabolic state because of the aggressive inflammation and necrosis that goes on with acute pancreatitis. So you follow the patient. Patient came on July 10th, and when the patient, you see them the following day, the next day, and you feel comfortable that you have adequately resuscitated them by your excellent IV fluid management. So now is day 2, day 3 coming, and you should be thinking about starting nutrition to take care of the catabolic state. And the preferred route is enteral, and if it is mild interstitial pancreatitis, you should start the patient on day 2 or day 3 with diet, oral diet, low fat solid diet. You don't have to start with clear liquids, full liquids, soft diet, and regular diet. You can just start with a low fat solid diet. One important thing that you have to keep in mind is do not wait for the pain to completely resolve, and do not wait for the pancreatic enzymes to normalize before you put your diet orders. So that is something to keep in mind. If the patient doesn't have vomitings and the patient doesn't have ileus, it's a good idea to start enteral nutrition and let the patient eat. If in case the patient had necrotizing pancreatitis, and in that case, how do you manage their diet? In those cases, you start a nasogastric feeding, as you can see here. You don't need to put a nasojejunal feeding. Nasogastric feeding works in most patients and as good as nasojejunal feeding, and start them with small peptide-based medium chain triglyceride. That's been shown to be the best formulation for enteral nutrition for these patients. And there are lots of benefits of starting enteral nutrition. And if the patient continues to have ileus, not able to tolerate, and in those cases, it is better to start parenteral nutrition. So don't delay the nutrition beyond 2 to 3 days, even in severe necrotizing pancreatitis patients. Something very important to keep in mind. So let me summarize the principles of medical management. In addition to pain control, two important aspects in the early phase of acute pancreatitis, whether it's interstitial pancreatitis or necrotizing pancreatitis. Think about hydration and nutrition, preferably by the enteral route. By hydration and correcting the volume deficit and improving the perfusion of the pancreas, you cut down the risk of necrosis of the pancreas. That means you are likely to uh, help the patient recover and go home uh, versus not being aggressive with your hydration to correct the volume deficit and letting the necrosis happen because you're not active in the first 24 hours. The first 24 hours is critical. Then the patient will develop necrosis. He will be in the hospital for a very long time. The second thing is, so the first 24 hours, focus on hydration. Day 2, day 3, you should be thinking about enteral nutrition, preferably nasogastric tube. No need for nasojejunal feeding tube in most cases. If there's ileus, then you may want to think about parenteral nutrition. Enteral nutrition is preferred because it allows the gut to move, improves the splanchnic circulation, preserves the gut barrier, and reduces the risk of bacterial translocation and infection, systemic infection, less risk of organ failure, and also has a beneficial effect on mortality. So I hope you appreciate how to manage acute pancreatitis. Hydration, 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 first 24 hours, till you correct your vital signs back to normal without fluid overloading the patient, and also following hematocrit to bring it below 45. Make sure that the BUN improves. And the next one is day 2, day 3, you should be thinking about nutrition, preferably enteral route. If they can eat, allow them to eat low-fat solid diet. If they can't eat, put a nasogastric tube. It can be done at the bedside, and you start the nasogastric feeding. I hope this is helpful. Thank you so much. Thank you.